Hello everyone. Today I'll be continue my discussion on disease of the small intestine, and I'll be including all these subspecialties which are relevant to my talk. So the first disease is celiac disease. This is a very important topic. VVIP. Throughout the world, whichever exam you appear, you always get one or two questions from this topic. Okay. So let's learn some basic concept about the celiac disease. First of all, it is a autoimmune disease. Point to be noted. Second point, it is a T cell mediated autoimmune disease. Why it is so important? Most of the time, when we have autoimmune disease, so many autoimmune diseases are there. They are all usually B cell mediated. But this is one exception, which is by the T cell. Point to be noted. Now what happened? What is the basic problem in this? The patient is intolerant to gliadin. And gliadin is a part of the protein gluten. And it is found in the food product like wheat. It means the patient is allergic to the protein, gluten or gliadin. But that is the part of wheat. Of course, there are other food elements also. Let's take about wheat, which is a very commonly eaten cereal. Bread is made of wheat. Now, classically, what that means when patient take any item, food item made of wheat, and he will have the problem. When he stop this, the problem disappear. So, in other way around, we can say it is a food related problem. Food related. This is again a key word to remember. Now, what happened? When the patient take any food item which contain gluten, patient has malabsorption and steatorrhea. That means there will be not only a problem of the absorption of the many food items like iron, folic acid, etc. But there will be steatorrhea also. There will be fat malabsorption also. And it usually affects the distal duodenum or the proximal jejunum. Site of disease is the distal jejunum or duodenum or the proximal jejunum. So here is the stomach. Here is the first part of duodenum, second part of duodenum, third part of duodenum, and here is the jejunum. So what we can say, it involves this third distal part of the duodenum and jejunum. Okay. So we can say, we can write other way around also, it tend to involve the proximal part of the small intestine. So we can say, right like this, it involves the small intestine, proximal part. This is a very important point, again a very, so proximal part of the small intestine is the key word to be remembered. Now what happened? A brief about why this problem occurs of steatorrhea and so-called malabsorption, because there is reduced mucosal absorption, and because villi are destroyed, and that lead to reduced mucosal absorption. And as I told you, is related to gluten. The other name of the disease is also known as gluten sensitivity enteropathy, and it is also known as non-tropical sprue. So friends, in this the key word to remember are T cell, autoimmune, gliadin, gluten, and small intestine proximal part, and gluten sensitivity or non-tropical sprue. These are the keywords number 1, number 2, number 3, number 4 and number 5. These are the 5 keywords to remember in this particular slide. Now what is the etiology? As we discussed in the previous slide, the main is gliadin is the main culprit, which is a part of gluten, which I just told you. But what is the most important? Where is this gluten present? Food item are barley, rye, oat and wheat, and the mnemonic is bro. Okay, remember the mnemonic bro. B for barley, R for rye, O for oat and W for wheat. So one is the food element, but there is HLA, it is also HLA associated disease, HLA-DQ2. It is there in 95% cases, and around 10% HLA-DQ8 can also be there. Okay, so point to be noted in this, there are two things to be remember. One is bro, second is HLA, DQ 2 and 8. So there are only two keywords to be remembered in this particular slide. The first keyword is bro and the second keyword is HLA, DQ 2 and 8. What are clinical features by which patient will come to us? First of all, there are two peaks. Okay, that means you can say it has a bimodal presentation. One is in the infancy, when the weaning is done. Weaning in done means, of course, throughout the world, one food habit which is common is the first 6 months of the life, where the child is given milk, and of course, after 6 months onward, they start introducing the oral food like cereals. So definitely, if the cereal contain whatever top feed is given to the child by feeding weaning food, if they contain any food item from the bro, barley, rye, wheat, okay, then the child will develop diarrhea. But second peak, this again 50 to 60 year is, and this is not known to most of the students. The keyword to remember here is weaning, bimodal presentation, the first keyword. And as I told you, introduction of the cereals in the infant diet, it is more in females, more in female. In fact, autoimmune disease are usually more common in females. So when the patient take any food, especially I'm talking about adult patient, they take cereal containing wheat, diarrhea, flatulence, weight loss, fatigue, all due to malabsorption. So what we can say, features of the malabsorption, right? So the keyword to remember in this are, number one keyword is bimodal, second word is female, and third keyword is features of malabsorption. Three keywords. Now let's talk about diarrhea, what diarrhea happens, why diarrhea happens. Steatorrhea, why? In fact, the basic pathology here is that there is the villi. These villi, they get atrophied and they become flat. So there is loss of villi, and loss of villi will lead to definitely diarrhea and steatorrhea, because of jejunum is the site where fat is digested and absorbed. So that's why patient develop steatorrhea. Okay, and that means one contributing factor for the loose motion is steatorrhea, fat. But in addition to that, and this is the reason being, if you can correlate with pathology, is mucosal atrophy. Jejunal mucosal atrophy. But one more thing that happened in the pathology is crypt hyperplasia. Very, very important question. So there is and so that due to crypt hyperplasia, this endogenous fluid secretion, the fluid will be secreted outside. So that means it will again contribute to diarrhea. So there is fluid secretion also. Okay, and in addition, there can be secondary lactose intolerance. About lactose intolerance, I'll be talking soon. That also contribute to diarrhea, and there may be bile acid malabsorption that again contribute to diarrhea. So there are four pathophysiology reason why patient has got diarrhea in this patient. The first pathophysiology is steatorrhea. Second is fluid secretion. Third is secondary lactose deficiency or intolerance. The fourth is bile acid malabsorption, which occurs in the ileum. So they all contribute to diarrhea. So there is a pathophysiology of diarrhea. Yeah. Anemia occurs due to iron and folic acid deficiency. The clinical applied, these two are absorbed in the proximal part of the small intestine. SI stand for small intestine, and that is the part which is mainly disease in this particular segment, and that's why iron and folic acid deficiency is there, and it's the one condition which can. So in this case, patient has iron deficiency anemia. You keep on giving iron, patient doesn't respond. So the clinical applied, it lead to iron resistant, iron deficiency anemia. Very important question. So this finding, you keep on giving iron, patient doesn't respond. Edema due to protein loss. We are having steatorrhea. There is also malabsorption of the protein also. So that lead to hypoproteinemia and that lead to edema. Osteomalacia, why? Vitamin D is a fat soluble vitamin. So there will be deficiency of all fat soluble vitamin will be there. And recurrent mouth ulcer again due to deficient vitamins. Now let us see what the pathogenesis. We read just now, I told you this because there is atrophy of the mucosa. Why and how? Let's go into deeper aspect of the knowledge. So we have in the normal lamina propria of the small intestine, there is an enzyme so-called tissue transglutaminase, what we write as TTG. So it is there, an enzyme in the lamina propria, especially of the small intestine. It is a deamynating enzyme. So it is definitely going to cause deamination. What is that? This is I'm going to discuss just now. Biochemistry aspect of the problem. Okay. And this enzyme, so-called tissue transglutaminase (TTG), is the main culprit behind the whole pathophysiology. Now, normally what it does, it absorbs gluten, which is absorbed. Okay, whatever gluten has been absorbed, it deaminates. Remember, it is a deaminating enzyme. So deaminase. So it will produce negatively charged gluten peptide. So what we are going to get is gluten absorbed in the small intestine, TTG. What it does? Deamination. Deamination. It will produce what? It will produce negative charged gluten peptide. So gluten is converted into a negative charge gluten peptide, and the enzyme involved is TTG, which leads to by deamination it becomes to negative charge particle. Now this gluten peptide which is negative charge, this is going to stimulate, this stimulates immune system. Point to be noted. Will it stimulate immune system of every patient? Not at all. Who are the patient? Those what we just studied, HLA, DQ, 2 and 8. So now in those patients who have a HLA, DQ 2 or 8, these patients will in this immune system will be activated, not in a routine patient, not in a routine person. Okay. So now these proteins will be taken by the antigen processing cell. Antigen processing cells. So this antigen processing cell, they will take this negative charge peptide. Okay. So now this negative charge particle has been taken by the antigen processing cells. Okay. Now these they present. So let's say this is the antigen presenting cell, and let us say here is the gluten. So antigen processing cell is carrying a nice gift as a gluten, and now this goes to CD4 cell, right? And CD4 cells, so it now this will stimulate CD4 cell, and they will release matrix proteases, and they will destroy the epithelial cells. So friends, if I have to give you the beautiful immunology part of the story, how the immune process, we have a gluten, first point. We have a TTG in the lamina propria, point 2. And this TTG convert gluten into negative charge gluten peptide. Now this gluten peptide will stimulate immune system. So now come the antigen processing cell. Antigen processing cell will take negative charge peptide, and they present to CD4 cell, and that activate matrix proteases which are going to destroy the entire epithelial cell. The key word to remember are number one is gluten, of course. Second is TTG. Third is negative charge gluten peptide. Fourth is the antigen processing cell. Fifth is the CD4 cell. And the sixth one is matrix proteases. I think I have simplified the entire immunology in the best possible way. And that lead to villus atrophy. So the patient has come to us, usually a child or maybe elderly person also. And now clinically we are thinking perhaps we are dealing with the celiac disease. The key factor which you really think, when you think, number one, First is iron resistant iron deficiency anemia. If we are getting a child iron deficiency, you must investigate for celiac disease. Second thing is especially elderly people. Well, let's talk about India. In India, the northern part of the India is mainly wheat based food, but in the south part it's all rice based. Classically, patient will come and he says, doctor, he's from any part, any city of the North India. He says he always have a tummy upset when he is in the north part. But he says, well, I went to South India and there I was perfectly all right. And he says the environment suited me the most. But again, I stayed there for 15 days. I was perfectly all right. But again, I come back to the North Indian city. Again, my tummy is upset. If you are getting these two word, either iron resistant anemia or you are getting change of food habit, you say what did you eat, he will say all the food items which were based on the rice. This is good enough for you to get a clinical clue that you are dealing with celiac disease. So now we are clinically suspecting. So what to do? Let's talk, then we'll talk about antibodies. Antibodies again, tissue transglutaminase, you remember? Yes, that was the main culprit. And the body develop antibody, that they will have an anti tissue transglutaminase, what we write as anti TG antibody, right? This is the most important. It is IgA antibodies. Now come the rank number one question, gold medal question. It is again a part of immunology, IgA antibodies, but they also have IgG antibodies. Why it is so important to stay a point that is important, IgA and IgG. The point is normally we always go for IgA antibody, but one problem which happen in celiac disease, they may have a deficiency of IgA deficiency, right? What is the meaning and significance of this line? I'll be talking to you in the coming slide only. But as of now, what I want you to make sure that anti-TTG antibody, they can be IgA and they can be IgG also. Routinely, we always check IgA, but in certain circumstances, we may have to go for IgG. What is that? Which I'm going to discuss soon. Highly very sensitive and very specific test. It is an excellent screening test. Similarly, we have an anti-endomysial antibody test, again a IgA antibody. Again very sensitive and specific, excellent screen test. But in clinical practice, normally this is most commonly used. So remember anti-TTG. We have anti-gliadin antibody which are IgA, IgG also. But it is moderately sensitive, good, not as sensitive as the previous two one. Anyway, one thing we have noticed, I discussed three antibodies, all of them are IgA antibodies. Okay, with this background of the three antibodies, we move on to important points. Well, there is one patient coming to me, maybe comes to you. Doctor, when I was in North India, I had a tummy upset. I went to South India. I was perfectly all right. Again, I have come back, my tummy upset. You are suspecting clinically that he is a case of celiac disease. You send for anti-TG TG antibody, IgA, and remember it's an excellent screening test, but it comes out to be negative. But clinically, I'm suspecting celiac disease. What to do? In such cases we'll go for IgG. So I'll say, okay, no issue. You go for anti-TTG IgG antibody. You have to specifically write that I want IgG antibodies. Now, why it became negative despite strong clinical suspicion? Because in these patient may have deficiency of IgA. IgA deficiency is a feature of that we can see in a case of celiac disease. The IgA is deficient. In such cases, the TTG test of which we have done with using IgA antibody will be negative. But in that case, IgG test will be positive. So now you understood why I mentioned about IgG and IgA, because it is very strongly that in many patients of celiac disease, there may be IgA deficiency is a feature, right? We are clear about it. So the two keywords, IgA deficiency, then you go for IgG based test. Two keywords. Well, finally, endoscopy is mandatory. What we get is scapuloduodenum in celiac disease. You can see classically, you get like corrugated appearance, so-called scalloped duodenum. The term they use is scalloped duodenum, right? We have done the endoscopy, so definitely when you have done the endoscopy, biopsy is the most accurate test. Point to be noted, I talked to you regarding antibodies, but I also told you they are screening tests, they are not diagnostic tests. Okay. So, biopsy to be taken from the proximal ileum. Why? Main site of disease is proximal ileum, so-called distal part of the duodenum or the proximal part of jejunum. Okay. And changes are most marked in the proximal small intestine. Why? Because primary digestion of the wheat, which is a starch, occurs in the proximal part of the small intestine. That's why maximum damage occurs in that part of the small intestine. Okay. So the only keyword is most accurate test is biopsy, and proximal ileum is the site of the disease. Okay. Now what you get in biopsy? I told you in the very beginning there is absence or villi, flat, reduced, so-called flat appearance of villi. Normally villi are finger shaped, but now they become flat. When they become flat, the area of absorption will be reduced. Normally villi are like this. Now the villi are become like this, flat. So area of absorption it will be reduced. But there is crypt hyperplasia. Remember, it was this which was causing lot of secretion of the liquid into the intestine. So we were getting that, so due to this reason we were getting secretory diarrhea. The two types of diarrhea, secretory diarrhea and the osmotic diarrhea. This I discussed in my lecture on small intestine part 1. Those of you who have not seen, for more detail you can see that lecture. There is increase in the intraepithelial lymphocytes. Inflammatory response is there. Okay. And the cuboidal appearance of the epithelial cell, they become cuboidal. Normally they are columnar lining, but now they become cuboidal epithelial will be there. But out of these two are the most important thing. Reduced height of the villi and the crypt hyperplasia are the two most important thing that you got to remember. The two keywords to remember in this particular slide, first and second. Okay, so now I can show you a lovely picture also. You can see this lovely picture. You can see normal, this is normal, jejunal. And here you are getting all the are lost, flat is there, right? And there are this crypt hyperplasia are there. These crypts hyperplasia are there. And there are lot of inflammatory cells. You can see plenty of inflammatory cells, so-called lymphocyte. So atrophy of the villi, crypt hyperplasia and lot of lymphocyte is a lovely pathology that we see in a case of celiac disease. Now one thing very interesting to talk. You have a patient of so-called celiac disease and he stops taking the food which you avoid, and after some time, after a few weeks, the histopathology become normal. This is a very, very important point to talk. Why so important? That means when we will be treating a case of celiac disease, the only treatment will be we ask the patient to avoid barley, rye, oat and wheat. That's the only treatment. Prevention is the treatment, and when the patient doesn't take this forever, remember this forever, then every problem will get disappeared. Okay, so treatment is gluten-free diet in summary. But one thing more. Even you have done the endoscopy, you have seen the scallop type of duodenum is there. Still, biopsy is a must because non-Hodgkin lymphoma of the intestine may be there. So it's very, very important that biopsy has to be taken when the patient come to you to rule out other important differential diagnosis of this having same type of presentation is clinically non-Hodgkin lymphoma which can involve the small intestine. So the keyword are it can revert back to normal, and biopsy is essential to rule out non-Hodgkin lymphoma. There are two keywords in this particular slide. Now, what are the associate condition? This again a very, very important VVIP. What are the classical? There are 5 or 6, but you don't have to forget dermatitis. First is dermatitis herpetiformis, DH. It's a chronic autoimmune blistering skin lesion. It is blistering. Okay, blister, that is anything which contain liquid. Watery liquid is blister. The first word is blister. They are grouped like they are in a group. Symmetrical. In any part of the body, they will like to have symmetrical problem, and they are very itchy, intensely itchy. So, dermatitis herpetiformis, blister, grouped, symmetrical, in the extensor aspect and very itchy. They are more in the extensor aspect, right? So, blister, group, symmetrical and itchy are the feature, okay, are the feature of dermatitis herpetiformis. In the exam, they will only ask about dermatitis herpetiformis. Patient come and they have got blister type of lesion, very itchy. In a patient of celiac disease is dermatitis herpetiformis. It is a cutaneous manifestation of celiac disease, definitely. Although the name is herpetiformis, but it is not related to herpes at all. This is a very confusing point. Often students think is related due to herpes. No way. They simply resemble like herpes. Group, vesicle containing liquid, but they are nothing to do with herpes. Okay. So their appearance is similar to herpes, but they have nothing to do with herpes. So by and large, there is nothing, no keyword in this particular slide. The keyword are 1, 2, 3 and 4 keywords are there. Now we talk about, okay, lovely picture. You can see these vesicles are there. In this you can see in the extensor aspect of the forearm. Here this you can see the back, symmetrical lesion are there both ways. Second association is type 1 diabetes, often associated. That's why the other name of celiac disease is diabetic diarrhea. Diabetes due to type 1 and diarrhea is due to celiac disease. So celiac disease having diabetes, what we call as diabetic diarrhea, and IgA globulin deficiency. I told you in some patients there may be deficiency. That's why in such cases TTG test for IgA may be negative. That's why we advise for IgG in such cases. And this is more likely to seen in Down syndrome and Turner syndrome. But nobody is going to ask you this question. But 1, 2 and DH, this 3 things you must know. Very important question. What complication can occur? Intestinal T cell non-Hodgkin lymphoma. Point noted. That's why I told you in any case of celiac disease, biopsy is mandatory. Although you have diagnosed it clinically, maybe by TTG also you have diagnosed, but an endoscopy and biopsy is mandatory to rule out this particular entity. They are also prone to small intestine adenocarcinoma. There are also squamous cell carcinoma of esophagus. Point to be noted. Point to be noted in the small intestine, it is adenocarcinoma. Point to be noted in esophagus, it is squamous cell carcinoma. And I hope you all remember that in the esophagus, it is the Barrett's esophagus, so called GERD, gastroesophageal reflux disease, can lead to Barrett's esophagus, which can lead to adenocarcinoma. Quite possible he will ask question about celiac disease, can lead to which type of esophageal carcinoma, and most of us are very well deep into our mind it is there that Barrett's esophagus is adenocarcinoma, and we mark for celiac disease also we mark adenocarcinoma. No, don't commit this mistake. Okay, the answer for celiac disease shall be squamous cell carcinoma. So first keyword, second keyword, third keyword. Refractory sprue. Remember, it is also known as non-tropical sprue. Refractory sprue, soon we'll talk about when we talk about tropical sprue. Tropical sprue is by some infective etiology, which we can treat by antibiotic. Here also the presentation is same like tropical sprue. And remember, the other name of this disease is non-tropical sprue. So you are giving antibiotic thinking is a case of tropical sprue, but not responding. So we call it refractory sprue. Patient keep on having loose motion because we are not aware that it's not a case of tropical sprue. There can be ulceration. This ulceration occur primarily due to if malignancy occur, that can lead to ulceration. Myopathy, neuropathy, maybe nutritional. Nobody going to ask you. But this is the most important, hyposplanism. So friends, which you don't have to, so this one thing you don't have to forget. And other is the 3. So overall, there are only 4 keywords to be remembered. The previous 3 words I have explained you nicely, but I like to talk more about. We have seen so many conditions where we have hypersplenism, but here we are getting hyposplenism. This is one of the beautiful question, ranked #1 getting question. 99% people are not aware of this point that in celiac disease, hyposplenism. The 4 keywords in the complication. Treatment, I don't think I need to talk more about treatment. You have to just stop the gluten containing food. The bro, the mnemonic, and the bro include barley, rye, oat and wheat is the only thing. In addition, you have to give, and what now, what? The question, one more question. What patient says, doctor, tell me what can I eat? You can say, yes, gentlemen. You can take rice, soya, bean, potato and corn. This he can take it. As a cereal, he can take rice. As a vegetable, he can take potato. As a soybean, pulse, corn also a type of cereal that can be taken by the uh, patient. Okay, and for dermatitis herpetiformis, we can give Dapsone. The only treatment is bro, avoid bro, and supplementation, iron, folic acid, etc., which are deficient, we have to give supplementation, right? So a quick recap of the last minute revision point. T cell mediated disease, gluten sensitivity enteropathy, bro, HLA-DQ2 and 8 bimodal presentation, diarrhea, anemia, edema, osteomalacia, anti-TTG antibodies, IgA or IgG, scalloped appearance on endoscopy, biopsy absence or reduced height of villi, flat appearance, crypt hyperplasia. Associated condition DH, type 1 diabetes and IgA immunoglobulin deficiency. Complication T cell lymphoma, small cell adenocarcinoma, esophageal squamous cell carcinoma, myopathy, neuropathy and hyposplenism. Treatment, remove bro and rice, soya, potato and corn can be given to the patient. Golden line to remember. Diarrhea after eating bro. We stop on avoiding them is celiac disease. Your question will be based on this line. Okay. So only, in fact, the entire celiac disease I can squeeze into one word, bro. Okay, celiac disease is bro. Your question will always carry some mention of the bro, and if you are getting any food item of bro, 99% you are dealing with celiac disease. So celiac disease squeezed in one word. Lactose intolerance. This occurs due to lactase deficiency. We are all well aware that it is the lactase which break down the lactose. Okay, lactose. Let's learn the basic biochemistry. Lactase. This break down into glucose, galactose. This is a normal biochemistry. Okay, so lactase is the enzyme which break down the lactose, and I don't uh, need to tell you that lactose is there in the milk. So now so definitely, if the lactase is deficient, this lactose will not be broken down, and this lactase or lactose which will there, that will be acting as a problem for the patient. So patient will say, whenever I take milk and I have the problem. So friends, and now again, this is a type of diarrhea which is related to any food item, but that is milk. So this the keyword is milk. Now where this lactase is there? Lactase is in the brush border enzyme. It is there in the brush border of the small intestine. Okay. And told you it break down glucose and galactose, like I've already written. And it's very common. In fact, it is a pan-globe problem, especially in Africa, Asia, and Native American descent. But what is more important, it may occur transient after it may occur after an acute episode of gastroenteritis. Quite as possible that many of the physicians they do say that after patient has come to you for a diarrhea and now is all right, and most of the physicians they say don't take milk for few days. Why? Because they have a transient transient deficiency of lactase for few days. That's the idea that don't take milk after gastroenteritis. So friend, as of now the keywords are lactase deficient. Lactase is a brush border enzyme and it convert lactose into glucose and galactose. The three keywords as of now. So we talk about more, and I told you lactose is there in the milk. So patient present to you after abdominal bloat, flatulence, gas, after taking milk. It's a type of osmotic diarrhea. Why? Lactose is a osmotically active molecule, so it lead to osmotic diarrhea. Point to be noted, the previous one, sick disease, was a type of secretory diarrhea and acidic stool pH, because later on colonic bacteria, the lactose which was supposed to be broken down by the lactase not getting broken down, now colonic bacteria will ferment lactose and they will produce acidic stool. So this the classical keyword are number one, milk ingestion, osmotic diarrhea and acidic stool. Okay, milk, acidic, osmotic diarrhea, MAO. MAO B inhibitor we use in Parkinsonism. So just remember the mnemonic is MAO, M for milk, A for acidic stool and osmotic diarrhea. Okay, in fact, this is the golden line. Entire thing will be based on these three words only. So now, till now, if I have to say, what all you have to remember is only two words. Bro is celiac disease, Mao is lactose intolerance. Whole thing squeezed in two words. Diagnosis, okay, is of course history is the most important. And when the patient says, when I take milk, I have problem, you think, you ask the patient to stop taking milk. The moment patients start stopping taking milk, he become all right immediately. Maybe in the very next day only you say, oh, today I am very perfectly all right. What did you do? Oh, I didn't take milk today. Remember, in celiac disease, stopping of the bro food item, it takes few days, few weeks to recover. But here the recovery is very fast. Why? This is the gold medal question. Gold medal question is why patient recovers very fast? Because here there is no damage to the mucosal lining. That means if you take a biopsy is normal. And enzyme is not there. The moment you don't, the patient doesn't take milk, patient become all right. Immediately within very few hours, he say I'm perfectly all right. So point to be noted, again gold medal line, biopsy is normal. Most of time students say that it's a atrophy of this, that, nothing, there's no atrophy, biopsy normal. Well, otherwise you can go for the lactose hydrogen breath test. Usually not done, but for the completeness, for the exam point of view, what is done? It is positive for lactose malabsorption. Okay. So what happened? You give lactose, and after that, of course, you give and you analyze the breath hydrogen values. If the value increases, okay, that indicate patient has lactose intolerance. Is anybody going to ask you the procedure? Not at all. What you have to remember is only this thing. Lactose hydrogen breath test, or they will simply say hydrogen breath test is positive in which condition? Answer shall be lactose intolerance. They will invariably going to ask you hydrogen breath test, right? So biopsy usually not needed. I told you it will be normal. Treatment is simply avoid any dairy product, and you can give oral lactase enzyme replacement can be given. But by and large, avoidance of the milk. But one more thing I like to add to you, practical point. We will be getting a lot of this very common disease, and even if you say that okay, patient will not take milk, he will obey you. But don't forget, milk is a good source of calcium and vitamin D. So never forget to supplement these patients. Practically, I am talking for calcium and vitamin D, who are likely to become deficient about these two things. Okay, this supplement should be given. So friends, easy to remember now. The keyword are lactase deficient. It is a brush border enzyme. Glucose, convert glucose into galactose. Milk ingestion of osmotic diarrhea and acidic pH stool, and hydrogen breath test, biopsy is not needed. So the only 6-7. So friend, diarrhea after taking milk, we stop on avoiding milk, is lactose intolerance. MAO is lactose intolerance. Even this is better than MAO, milk, acidic pH, osmotic diarrhea is lactose intolerance. Your question will be from this only, nothing will come from outside. Whipple disease. Now, it is a chronic multi-system disease. Point to be noted here is, so far whatever we have discussed the diseases regarding small intestine, they are usually confined to the problem of the intestine, diarrhea, steatorrhea. But here it is not a disease, it's a multi-system disease. That means other than GIT, they'll be involving many other system also. Usually involve occurs middle age or older male, right? So the first keyword is multisystem, older male, caused by gram-positive actinomycete, so-called Triphorema vipelli. This is the third keyword. So microbiology, Triphorema vipelli. Okay. So I told you it's a multi-system disease. It involves many other diseases. So far there are only two keywords to remember. Multi-system disease involving the middle and older males, and Triphorema vipelli are the three keywords in this particular slide. So you can see this organism. You can see one more picture, but make a note of something. What is this? Why it is so important to show you? I'll discuss in a couple of minutes. Clinical features: diarrhea, steatorrhea, etc. All the GIT features, but there is something more: protein losing enteropathy. So, other than the diarrhea, steatorrhea, the usual feature of we are getting protein losing. So, definitely patient is going to lose protein. This is regarding GIT. And one more thing, it's a multi-system disease, but let's see, it may involve the joints, migratory large joints, point to be noted. And they do not do any deformity, so they are non-erosive arthritis. Now I have a question for the student to answer, question only for the students. Tell me any other disease you know of where large joints are involved. Number two, they are migratory. And third, they are non-erosive, so-called non-deforming. Tell me any important disease you know of, only one disease. Write down the answer in your copy, only for students. The answer is rheumatic fever. But point to be noted, rheumatic fever occurs usually in the younger age group. And of course, the additional features are there. But we learned that Whipple disease is the disease of the middle or the older people. Point to be noted. Well, in the multi-system, lungs involvement can be pleurisy or lung infiltrates. Cardiovascular also may be coronary arteritis. Is okay. That means it's going to cause problem in the coronary artery, but in the form of arteritis. Maybe pericarditis, maybe conduction defect. So if I have to draw a diagram, this is the heart. In the heart, this is the pericardium. The patient can have pericarditis. Here is the blood vessel, coronary arteritis. And here is the conduction system. The conduction system may be involved. So pericarditis, arteritis and conduction defect can occur in this patient. CNS is the one which is most commonly asked after the GIT, and joints. Patient can have various type of neurological manifestation, seizures, myoclonus, dementia. Point to be noted, dementia. And there may be hypothalamic syndrome like insomnia, hyperplasia, okay, polydipsia, hyperphagia, it is hyperphagia, okay. But out of these, don't forget dementia. Why? Dementia is loss of memory, so it is a treatable cause of dementia. We are well aware that like untreatable are Alzheimer's disease, which are irreversible. So we can say it's a type of reversible dementia. Reversible dementia. That's why important. Forget everything in CNS, but don't forget dementia. So whenever we talk about reversible dementia, extra edge point, the reversible dementia, whenever we talk about B12, B12 deficiency and hypothyroid, subdural hematoma, SDI stand for subdural hematoma. So they are the three very important causes of reversible dementia. To the add on to list is Whipple disease also, right? Ocular involvement may be, eye involvement may be ophthalmoplegia, uveitis can be there. So a quick recap, but all you have to remember is number one is diarrhea. Protein losing enteropathy is the first keyword. Migratory non-erosive arthritis. There can be pulmonary infiltrate. There can be arthritis, coronary arthritis, pericarditis or conduction defect. 4. Fifth is reversible dementia. Sixth is uveitis. So there are 6 keywords to be remembered in this particular section. Lymphadenopathy and chylous type of ascites may be a feature. Okay, chylous type of ascites, which is more we like to contain chylous, but not a very important finding. So let's talk about pathology. What type of finding you get is, you are getting irregular fold pattern and thickness. You can see this irregular thickness, folds are there in the intestine, of course, right? You can see irregular type of folds are there, thick folds are there. Well, histology. Invariably in the exam they will ask you, this will be there, pass positive foamy macrophage in lamina propria. This is the most important finding for exam point of view. Invariably examiner will be asked you, a patient come, joint pain, diarrhea, dementia, blah blah blah, and finally he will always say the biopsy was done that contained pass positive foamy macrophages in the lamina propria. So you can see these are the type of finding you get is. This is Whipple disease. So entire Whipple disease is just squeezed into one line, pass positive foamy macrophages in lamina propria is Whipple disease. Biopsy, the most accurate test, which I just mentioned to you in the previous slide, pass positive. Okay, and now, but there is something unique thing. We in the lamina propria, we contain foamy macrophages. Yes. Now, what is the foamy macrophages? I talked to you regarding foamy macrophages. Okay, but what do you mean by this foamy macrophages? Let's talk more detail. So these macrophages, they contain rod-shaped bacilli and they contain pass positive material. What is this? This consists of granules of lysosome and partially digested organism. I repeat again. In the biopsy lamina propria, we get foamy macrophage, and now I'm taking what does it contain? It contains the organism, and it contains pars positive material, which is nothing, lysosome and partially digested organism. Got it? But point to be noted, this organism, Porphyria vipli, it proliferates within the macrophages. Very, very important point. In the macrophages only they are going to proliferate, not outside. So the main thing is no inflammation. So there is no inflammatory cell. If you recall, in celiac disease, there were lots of lymphocytes were there. There was a crypt hyperplasia, there were lot of lymphocytes were there. But here there is no inflammatory response. This is a gold medal getting question in pathology. The one disease where the inflammatory response is not there, and that is Whipple disease. No inflammatory response seen in these patients. Right? No inflammatory response is seen. So friends, pars positive, lamina propria, no inflammatory, so-called foamy macrophages, that's all. The other four keywords are good enough to diagnose a case of Whipple disease. First is lamina propria, second is foamy macrophages, third is pars positive, and the fourth is no inflammatory response. Treatment, trimethoprim and sulfamethoxazole. But in resistant cases, we can, or the patient who are allergic to sulfa, in this chloramphenicol can be given. Normally in any exam, they never ask the dosage. But this is the one question which can be asked. The question what comes that in a case of Whipple disease, we have to give this combination, so-called co-tremexazole. It usually come in the sense of double strength DS, it come double strength. Now I have a question only for the student to write down the answer. I have one patient of Whipple disease and I want to give co-tremexazole. For how long I have to give? Option A, single dose stat. Stat, only one. You give twice a day, BD, for 7 days. You give twice a day for 4 weeks. You give twice a day for 6 months. Or you give twice a day for 12 months. How much, for how long you give A, B, C, D? So lovely question for you. You get 30 seconds to think and answer. Write down the answer in your copy. Question only for the students. Well, the right answer is for about 12 months. Beautiful question, but very frequently asked question. So, a quick recap of the LMRP last minute revision point: Porphyria vipuli, diarrhea steatoria, non-erosive arthritis, lung infiltrates, pericarditis, reversible dementia, uveitis. Most accurate is biopsy and co-tremexazole for 12 months. This is all for LMRP. So, write down the golden line. Lamina propria, patient with diarrhea, and the biopsy shows lamina propria having pars positive material. This is Whipple disease. A patient with diarrhea and the biopsy shows lamina propria containing past positive material is Whipple disease. Tropical sprue is a condition, chronic condition. Patient has malabsorption and it occurs in the only people who live or they have visited the tropical country and gone back. Since the disease of the tropical region, that's why it is known as tropical sprue. And it is a type of environmental problem. Why environmental? Why, what need? Because this is seen only in tropical region. It's not seen in the temperate area or other places. So it means it is a one disease which is confined to a particular segment of so-called tropical area. That's why it is a type of environmental enteropathy is there, right? Etiology, in fact, is usually unknown. But they say, it's usually not known, but they say, since it is seen in people who live in the resident area or those who visited to tropic, perhaps this is infectious in etiology. Certain organism has been proposed. Infection like Klebsiella, Enterobacter, E. coli, maybe it can be toxin also. Nothing is full proven, but they proposed it to be. But one thing there, it is usually agreed is an infectious etiology. The key word is infection and recent visitor to the tropic. In your exam, it will be recent visitor to the tropic or maybe a infection, the only two keywords so far. Pathology is similar to celiac disease. Same pathology is there. There is the flattening of the villi, but they respond to antibiotic. Point to be noted when I discuss regarding celiac disease, I say is a type of non-tropical sprue. In fact, celiac disease is very common in UK and Ireland area. Anybody going for Ireland exam, there will be invariably, because very common in Ireland. So definitely in MRCP exam in particular, they are going to ask a lot of questions on celiac disease. But remember, this disease occurs pan-globe. May or may not occur, celiac disease question will be there, and that is known as non-tropical sprue. Same pathological finding is there as tropical sprue. But again, one point we differentiate is respond to antibiotic. If you recall, the celiac disease is what we call as non-refractory sprue, but they were not responding to antibiotic. Same, reduce mucosal absorption because there is a flattening of the villi. Okay, but again the disease starts from duodenum and jejunum. Same what we got in celiac disease. But here additional finding. In due course of time, even distal ileum may be involved. And here comes the clue. If this is problem, iron and folic acid deficiency will be there. But if this item has come, then B12 deficiency will also be there. Point to be noted, B12 deficiency is not a feature of celiac disease. Celiac disease is a disease of the jejunum and the duodenum. But here, the two extra things that we are getting, this tropical sprue, number one, it responds to antibiotic, and second keyword is there can be B12 deficiency, but that occurs in the later stage of the disease, not in the early stage. Symptoms same: diarrhea, fever, malaise. Suppose that there is one gentleman who has come back from any tropical country. He has loose motion, so he will have acute diarrhea. Definitely, every diarrhea has to start, even chronic diarrhea has to start with the acute diarrhea. But in chronic diarrhea, at time, it may be not be that prominent manifestation, but here we have clear-cut history that patient has acute diarrhea. And later on, patient go into chronic phase, steatorrhea, weight loss, anorexia, all the feature of chronic weight loss. And folic acid and B12 deficiency later on, the point I mentioned to you. So friends, to begin with, acute diarrhea. Later on, chronic phase, where we'll have steatorrhea and all the features which I've been talking to you in so many time previously, weight loss, steatorrhea, and vitamin A, D, E, K deficiency, etc. Iron, folic acid deficiency will be there. So in this case, diagnosis, as I told you, we are going for biopsy. Is by biopsy. I don't need to repeat again the biopsy finding. Same as what we got in case of celiac disease. Again, there are inflammatory cells, lymphocyte will be there, which were there in celiac disease also. And there will be deficiency of all the vitamins. I don't think I need to repeat again. Steatorrhea, excess fat will be there. Thickened mucosal fold on imaging. So by and large, everything is same as celiac disease. Alright. But again, remember, you are getting a patient. Suppose the patient come to you right now, you have got diarrhea, etc. All the features same as tropical sprue. What you do? First thing you do, ask the patient to stop, bro. Patient get respond and ask him to come to you after 3, 4, 5 days. And he come back, if yes, I am much better now. You continue with celiac disease profile. But even after stopping for about 7, 10 days, problem continues, then perhaps you are dealing with tropical sprue. Give antibiotic then. Tetracycline for 6 months. And of course, you give all the supplement, and this is common in all the diseases where we have steatorrhea. So, golden line to remember. Diarrhea occurring in a Caucasian or European patient who returned from any tropical country. You think about tropical sprue. Tuberculosis of the abdomen. And of course, in such cases, there may be history of TB in the chest. May or may not be there. But one thing is sure, that when the abdomen is involved, the commonest site is ileocecal area. This is a very, very important line. There are two reasons why it is such a key word. First of all, Crohn's disease. That also involves the same ileocecal junction. And Crohn's disease is a very, very important differential diagnosis of this. And second, there is deficiency of B12, because ileum is the site where B12 deficiency is there. Point to be remembered, in celiac disease, B12 deficiency was not a feature. Point to be noted that in tropical sprue, B12 deficiency occurs on the late phase. But in tuberculosis, B12 deficiency is the feature. So these are the two, they are the keywords to be remembered. Now, in addition to that, it can involve ascending colon, jejunum, appendix, but they are uncommon sites. I have mentioned the name. Do you need to remember? Not at all. Not at all. The purpose is invariably they will other places are very uncommon. Especially stomach and esophagus are very uncommon. Okay. So exam question is ileocecal junction. Now what type of pathology we are going to get it? One is the ulcerative type. This is most common. So here is the small intestine. The ulcer formed is in circle. It is a circular which is around. So it is perpendicular to the long axis of the intestine. This is the long axis of the intestine. But the ulcer form is perpendicular. Since it is a type of circular, so stricture formation is a feature. This is a very important question. Invariably, when they will ask this question, they may ask you, a related question is, in typhoid we get longitudinal. In typhoid, you get this type of ulcers. They are parallel to long axis of small intestine. So that's why in typhoid, also called enteric fever, no stricture. But here we have stricture. Stricture formation occur in these patients. So you can see they that like this, ulcer is there, so called ulcerative type. Then hypertrophic. There we have scarring, fibrosis or mass lesion, mimic like carcinoma. So you palpate the right lower quadrant. RLQ stand for right lower quadrant, and you may get a mass. You can palpate. Okay, so it looks that it is like a cancer. So classically, if you are getting a mass or a lump in the right lower abdomen, think of tuberculosis, think of Crohn's disease, think of amoeba. Amoeba is due to amoebiasis, and of course cancer. They are the 4 important DD of any important lump in the right hypochondrium. So now you can see it's all hypertrophied, and if they become hypertrophied, they are definitely going to reduce the lumen. So they are going to reduce the lumen. Lumen will become narrow, and it will have some finding which I am going to discuss in a minute now. Third is ascites. Classically, patient come with a massive ascites, and it will type of exudate. Okay, right? So you may get a type of exudative ascites where the patient come with the tuberculosis. And finally, you may get lymph node enlargement, so-called lymphoglandular type. It is usually seen by CT scan. These are the patients who usually come to us with PUO, pyrexia of unknown origin, or so-called FEO, fever of unknown origin. Okay, unknown origin. Pyrexia of unknown origin or fever of unknown origin, patient come to us, then you go for CT abdomen and you can find mesenteric lymph nodes are enlarged. You can see lovely lymph nodes are there. So if you are getting a mesenteric lymphadenopathy, one of the strong differential diagnosis for this condition is tuberculosis. Of course, you can confirm by FNAC. Fine needle aspiration and cytology that we can do in this patient to confirm it. So how the patient come to us? Chronic pain abdomen is the most common presentation. Long-standing pain will be the features. Diarrhea may be a feature, but due to obstruction, sometimes patient may have an altered bowel habit also. Blood in stool may be there. Vitamin B12 deficiency. For exam point of view, this is the most important point. Okay, or pain abdomen. Otherwise, low grade fever, weight loss, which are all the feature of tuberculosis will be there. Complication, bleeding, perforation can occur but uncommon. More of a hypertrophy occurs. So obstruction is more common. Is more common. Perforation is more common in type ka enteric, but here obstruction is more. There may be fistula formation or malabsorption may be there. Out of all these, you forget everything, but don't forget obstruction. Is you got to remember. Investigation, X-ray, chest also, abdomen also. You may get calcified lymph node, but not going to add to our diagnosis. Multiple air fluid level, this may occur when there's some obstruction is there. But again, it's not going to give us a diagnosis of tuberculosis. Dilated loop again because of obstruction. They are just a non-specific finding. But we go for barium meal study. They will indicate hypermotility. Now come the exam questions. He is going to ask you this thing. One is Sterling sign on barium studies. What is this? The disease segment is not able to retain the barium. Okay, let's say this is the small intestine and here we are getting a disease part, hypertrophied segment is there and it occurs in the terminal ileum and this is the cecum. Now this disease part is not able to retain the barium, it immediately goes to the next component. Okay, so this is so called Sterling sign is there, disease segment of the barium which is retained by the normal segment. Disease part doesn't contain, so that is so called Sterling sign. String sign, it is much more commonly asked. Well, you can see the terminal ileum, you can see in this particular barium study, the terminal ileum has become like a thin ribbon like a string sign, thin segment of barium resembling a string in the terminal ileum. Okay, I can show you. This is the ileum and here we are getting like this. There is a barium coming. So a thin segment as I show you here also. I can rub it out for you to for better visibility. Yeah, it's beautifully visible now. So this how so-called string sign, and this is both these signs are seen in Crohn's disease also. And as far as ascitic fluid is concerned, it is a exudate, lot of lymphocyte predominance, proteins level are very high is the features of exudate, and we can take a punch biopsy in some cases. CT abdomen is going to help us by showing the lymph node also or ascites also. Treatment is anti-tubercle treatment. ATT is anti-tubercle treatment for 6 to 9 months. And if the obstruction is there, in such cases you can go for surgery, but not in routine cases, only obstructive pathology is there. Golden line to remember in the exam, if you get Sterling sign or string sign in barium study, it is seen in Crohn's disease as well as TB abdomen. Okay, if you are talking like this, or you are getting a circular ulcer, you are dealing with tuberculosis. Or B, you can write down one more thing, B12 deficiency, circular ulcer, you are again dealing with TB abdomen. They are the golden line to remember in TB of the abdomen. Thank you very much. God bless all of you.